So the timing is a big part of this. We can time the IUI. We have some flexibility. There's a window during which the egg will survive, and that can be as long as 24 hours. So we want to get the sperm in there to meet the egg during that window. So the timing can be optimized using a trigger shot. So if we're monitoring the cycle and we know when everything looks optimal, we can use the trigger shot to tell the egg to come out for ovulation to occur. And then we can time the IUI most optimally. So that sometimes may be of benefit. The technique of the IUI, of course, is important as well, making sure that the catheter goes all the way up into the uterus and the sperm all are placed closest to the fallopian tubes with the best chances of them reaching the eggs. Medical treatment can be combined with IUI. So for unexplained infertility, for example, we often use a concept of superovulation, where we use medications like Clomid or letrozole to try to increase the number of eggs that are released. Normally, one egg is released per month. That's the natural cycle most of the time, sometimes more than one. That's how natural fraternal twins, for example, occur. But we can boost the odds of success by releasing more than one egg with these medications, thereby increasing the chances that one of those eggs will be normal and gets together with the sperm and achieves success. It comes with a price, and that price is risk of multiple gestation. The more eggs that are released, the higher the chance of more than one baby occurring. And we usually will not proceed with the cycle if there are more than 3 eggs about to be released. So we would cancel if there's too high a risk of multiple gestation. And just to be clear, we try to avoid multiple gestation because we know that even twin pregnancies are high-risk pregnancies, and anything that can go wrong in pregnancy is much more likely to go wrong with twins than with a singleton. Next question. How many eggs? Oh, I lost it. 1 second. There we go. How many eggs can be retrieved each round of IVF, and how many are needed for a successful fertilization? So the first part of the question is it's very much varies. So we can retrieve no eggs. Sometimes something goes wrong and 0 eggs are obtained, or we can get 50 eggs or even more. So the number varies dramatically depending on the individual's ovarian reserve and how they respond to stimulation, also the type of stimulation that we use. So the number is highly variable. On average, we're looking for something in the teens as being a good number to aim for. But in the end, the quality of the eggs is more important than the quantity. So in a young individual in whom we obtain 6 eggs, it's possible that all 6 will be great quality and produce fertilize and produce embryos that progress to blastocysts that have a great chance of success. Whereas in an older individual, we may be able to get sometimes, luckily, 20 eggs, but find that only one of them may be normal and succeed. So the numbers vary dramatically. The other part of the question is how many are needed for a successful fertilization? Well, we only need one. All we need is one good one to succeed. But we try to get more so that we boost the odds in our favor. The more eggs we get in general, the higher the probability that we'll find a normal egg and have a chance of success with that egg. All right. Moving on. The first question here in the chat, we have a 42-year-old individual, first pregnancy at 38, delivered at 36 weeks with multiple abnormalities. Second pregnancy, 39, at I'm not sure if this is this is age. Okay, at the age of 39, ended prematurely at 26 weeks. Unfortunately, baby did not survive and died from infection in the NICU, in the neonatal ICU. And then a lot more information here. IVF cycles. Two IVF cycles. with poor outcomes in that no normal embryos were achieved. Then had a fibroid surgery and looking for chance of natural pregnancy. Wondering about future success of possible IVF cycles and feeling hopeless. Well, I'm so sorry to hear that. This is a very difficult history, and it's hard to even find words that can provide comfort or support here. But I don't think you're without hope at this point. The main concern clearly now is age and the quality of these eggs. In the first IVF cycle, there was an adequate response, 7 eggs retrieved. 1 made it to blastocyst, but unfortunately chromosomally abnormal. So that demonstrated to us that you did respond somewhat to stimulation. So that says that there's still a chance of success and that there's a chance of finding a normal egg. But the majority of the eggs, unfortunately, are abnormal. And then the second cycle, none of them progressed to blastocyst, and that's certainly extremely upsetting and disappointing. But it is not unreasonable to try again, because it appears that you are responding to stimulation. And so as long as you're responding and we can get several eggs, then there is a chance of finding one good one and therefore having success. So it's kind of like throwing the dice and hoping that they turn up in your favor. Admittedly, the odds of success are unfortunately low. Age and your response to stimulation predicts how you're going to respond next time. And so we know that you're not going to have great response no matter what type of protocol is used. And then we know that the majority of the eggs will be abnormal. So it's just a matter of a small chance of finding that one good one in the bunch that are abnormal. So there's still hope, but the odds of success are low. For a higher chance of success, then we would consider other options like donor egg or donor embryo, and that would give you a much higher chance of success. Now, secondly, there's another issue now, the fibroids. So fibroids do not impact the egg quality or your response to stimulation usually, but would potentially impact the chance of a successful implantation. So if the fibroids have been removed and the rest of the uterus now is in good shape, and making sure that's going to be important going forward. But if the uterus is good, then you would have a great chance of success with donor egg or donor embryo if it does not succeed, if you do not succeed with your own eggs. Chance of success on your own is still possible, because at 42 years of age, you still have eggs, and as long as you're ovulating, there's always going to be a chance of pregnancy. And so month after month, each month is an attempt. You would have some chance of success, and although each month the success chance is very low, over time you will have some shot at it. But as you get older, the fertility will continue to decline. So unfortunately, odds of success are low, but there is still hope if you want to try with your eggs another time, and certainly a much higher chance of success with donor egg or embryo. That's the best I can say given the information here, but a complicated case that would definitely take some time to review and come up with best recommendations. And lastly, I offer hope to you and my best wishes that you can find success. Next question. Why is that? Why is it important to wait a year to get into fertility treatments? I'm 34 and my husband is 42, and we already have a chemical pregnancy. Since then, I haven't been able to get pregnant, and I'm doing everything I can, basically, regular periods, ovulation. So you don't have to wait a year to begin fertility evaluation and fertility treatment. And certainly at the age of 35, we start urging that happen faster, just 6 months. It's not a year also of trying, it's a year of unprotected intercourse. So if you have not been preventing pregnancy, that is not pulling out, not doing condoms or anything, and no pregnancy has occurred, then and it's been a year, then you have the diagnosis that by definition of infertility. If there are any other issues, then also no need to wait for the full year mark. The year mark is more for insurance purposes. The insurance sets that as a goalpost because many pregnancies, let me rephrase that, because they don't want to pay for unnecessary testing and put you through unnecessary testing. So it's, however, quite evident from all our data that most pregnancies will occur within the first 6 months. And therefore, if you're not pregnant by 6 months, it becomes less and less likely that the pregnancies are going to occur in the next 6 months. But still, even in the second year, as many as 10% will still get pregnant. So pregnancies will still occur, even if they haven't happened in the first year, but it just gets less and less likely. So to answer the question, it's mostly for the purposes of deciding where to put a cutoff, who should be put through testing. And if you start testing on the early side, you're going to spend more money for the system and for the individual and put them through potentially unpleasant tests. On the other hand, waiting longer, you're losing time and creating frustration. So there's it's a balance. And so the balance has been at 1 year for women under 35. But if you want to, we can certainly start the workup at any point. We don't have to wait. It just may be an issue that sometimes insurances will not pay for that workup if it's done before the formal diagnosis of infertility can be made. But you're always welcome to come for a consult, and we can evaluate that and decide if it's appropriate, if it makes sense to start testing now if you want to, or not. Next question. Are you familiar with immunization therapy for repeated unexplained miscarriages? Then there's some history about family history. And then for the individual, had 2 miscarriages and all the testing has been normal. So anytime that there are recurrent pregnancy losses, it's one of the more frustrating things to deal with. We do the workup, and we can be thorough looking for anything that we know that causes miscarriages. And if we don't find any explanation, and that's about half the time, then it's an even more frustrating situation where the miscarriages are unexplained. And so if we don't have a specific reason, then we don't have a specific treatment to fix something. So we start talking about empiric therapies. Workups for recurrent pregnancy loss vary from center to center, from doctor to doctor, depending on the individual preferences and individual situation. So there are other tests that may be considered beyond the ones that you mentioned. So chromosomal testing for both partners, antiphospholipid antibody testing, making sure that you've got the important ones covered. That's anti-cardiolipin antibody, IgG and IgM, antiphospholipid, beta-2 glycoprotein 1, IgG and IgM, and lupus anticoagulant. So making sure that those were tested. And thyroid testing, those are 3 of the most important causes, but there are other things to be considered as well, including evaluation of the uterine cavity, making sure nothing's wrong inside the uterus, such as polyps, or things we mentioned at the beginning of the conversation this evening, scar tissue, fibroids, extra wall, a septum, as well as possibility of infection inside the uterus or inflammation from abnormal bacterial biome. So there are other tests that can be done if they haven't been done already, looking for some causes that may be at play. There are treatments that are empiric, meaning that we're not treating any one specific thing, but we're just trying simply to boost the chances of successful implantation in pregnancy. And those can be decided on an individual basis, depending on your history. So these include steroid treatments, blood thinners like Lovenox, steroid treatments sometimes. Immunization therapy is something that's been largely shown not to be helpful. by large randomized clinical trials. So that's not something that's done routinely, only in very rare cases that we would do something like that at this point. So complicated question, deserves a lot more attention. So definitely would welcome you for a more complicated and more detailed discussion. Next question. What are your recommendations of do's and don'ts for after a frozen embryo transfer? Is there any magic to sleeping on a certain side, etc.? So I like to say that in the old days, and by the old days I mean like 3 years ago, we used to tell patients that it was important to be on restrictions of activity, not lifting heavy things, maybe even sometimes recommendations were for bed rest. Those recommendations have all been dismissed. There have been studies that show that activity does not impact the chance of success, and in fact may be helpful. So continue to live a healthy lifestyle with some moderate exercise may be quite good. Whereas bed rest in one study was actually shown to be detrimental and decrease the chances of implantation compared to others who were not on bed rest. So at this point, I do not recommend any restrictions after frozen embryo transfer unless there was a certain protocol of stimulation that caused your ovaries to be enlarged or anything like that, or if your individual case requires any specific considerations. But in general, no specific restrictions. And the general advice would be to simply live as healthy a lifestyle as you can, and not exhausting yourself, certainly not the time to start a new workout routine and go to boot camp or train for a marathon, but a time to maintain healthy lifestyle with eating healthy, fresh foods and less processed foods, more protein, less carbs, exercising lightly or in moderation, trying to manage stress. So that would be the best. And there's nothing else in terms of sleeping on one side or any other magic that I can recommend. Next question is, I'm about to take a trigger dose in advance of IVF implantation. Are there any particular precautions I should take from now through the time shortly following implantation to ensure best probability of pregnancy? So I think we just covered that in the previous question. Other sections to this question. If your partner's been exposed to any infections, such as COVID, then certainly would want to avoid contact with that individual. So any infectious disease or any illness at this point can be harmful to your chance of successful implantation. So I would very much avoid and minimize the risk of becoming infected with anything. So if your partner or anyone that you're associating with could be infected, I would take all the precautions and try to distance yourself, use the best hygiene in terms of hand washing and wearing masks, but trying to use all the precautions that you can look up on the CDC website for avoiding contact and avoiding becoming sick. That's one of the most important things you can do to improve your odds of success, not getting sick. Given failed IVF, would I revert to IUI, or would that be pointless? So usually, if you've progressed to IVF, then IUI is unlikely to be a successful strategy, since for most cases, it has a significantly lower chance of success than IVF. So depending on what happened in this case, maybe IVF can be repeated, or maybe they're frozen embryos, or whatever the scenario is. Of course, I don't know the details, but it is not common to go back down to less aggressive treatments, although in some cases it does make sense. So for example, in someone who is much older, as in the mid-40s, the chance of success with IVF is usually going to be very low, especially if there's poor response. Or for any age, if there's poor response and very few eggs are being achieved, then success with IVF may be no better than with Clomid and IUI, for example, if the tubes are in good shape and there's adequate sperm. So in some cases, it does make sense, but that's the exception rather than the rule. How can you increase or help to better your egg health and to produce more? Are there over-the-counter vitamins? And is CoQ10 a good idea? So in general, unfortunately, there's very little that one can do to improve egg quality. And we don't think anything that one could do to improve egg quantity. So from the quantity standpoint, we know that every woman is born with all the eggs she's ever going to have. And as she goes through her life, she's using up those eggs until there are no more eggs, and that's menopause. So we can't do anything to improve the ovarian reserve. We can't put new eggs back into the ovaries. We can't flip a switch and make new eggs. What you have is what you have. That's what we have to work with. Now, there are things that you can do potentially to improve egg quality, although usually that's not going to be a major impact, but there are potential benefits from various interventions. So number one, most important, again, is lifestyle. Living as healthy as lifestyle as possible. And that means already things we've touched on, which is eating well, and that's fresh foods versus less ultra-processed foods, protein, high protein diets, low carbs, exercising in moderation. If overweight, trying to lose weight and try to return towards normal weight as much as possible. Control blood sugars, if that's an issue, and control mood. So depression, anxiety, getting help, coping strategies, all has been shown to improve sometimes outcomes with IVF. Supplements, none have been convincingly and clearly shown to make a difference. Of all the supplements out there, the coenzyme Q10, CoQ10, is the one that has the most positive evidence behind it, most of it from animal studies. And so it does suggest that there may be some improvement in egg quality if using CoQ10. So if there's any one that I would recommend using, it would be that one, but I can't consistently recommend it because I don't have clear data to show that it makes a difference. And another question talks about mental health and IVF, and we just hit on that as well. So yes, controlling stress, whether it is simply having someone who listens to you and understands and provides support, or if you need more through a therapist, or sometimes acupuncture has been suggested. All of these things can potentially help you deal with stress and thereby potentially improve chances of a successful IVF cycle. Next question is from a 25-year-old who has never been pregnant before. And after several tests, everything appears to be normal, regular cycles with ovulation, husband at 31, who's been found to have low sperm count and low motility and lots of abnormal sperm. Could IUI be successful, or would IVF be preferable? So this is a pretty clear case based on this information that the main issue appears to be male factor, sperm abnormalities. And so there are several things that can be done to try to help you succeed with pregnancy. So one road that can be followed is to be seen by a urologist that specializes in male fertility. So a specialist urologist, not just a general urologist. And that urologist would check your husband and see if they can find anything that's causing these sperm problems. Sometimes they find something specific, and if they find something, they maybe can do something to make it better. So perhaps there's a dilated vein around the testicle called the varicocele that can be snipped, or maybe there are low testosterone levels and maybe taking medications to improve testosterone production, or maybe he's taking medications that he shouldn't be taking that are hurting, or his lifestyle. So there are a number of things that the urologist can potentially find that the urologist can address and improve sperm quality. Having said that, we also have to say that most of the time, the workup does not find anything specific, but it's still important to do because it could be important for his health, not just for his fertility. Sometimes the sperm abnormalities are just one sign of a more global health problem that could be important to catch at this point. So seeing the urologist would be recommended regardless. Now, from our standpoint as fertility treatments, we do have two main options of either using IUI or IVF. And so we already covered the difference earlier tonight, but just to quickly review, IUI is intrauterine insemination, where we take all the good sperm and put the sperm with a little catheter up into the uterus at the right time when the egg's coming out. So in order for the IUI to work, you need enough good sperm for there to be a good chance of one of them making it to the egg. So in general, a rough ballpark figure is when we're putting the sperm in the uterus, we're looking for a total motile count, total number of moving sperm that we're putting in to be about 5 million or more. If the semen analysis shows that numbers are good enough for that to be possible, then IUI is a very reasonable strategy to get a decent chance of success. On the other hand, if the sperm abnormalities are very severe, the counts are very low, motility is very poor, very few normal sperm, then the IUI is not likely to help unless the urologist is able to improve sperm quality first. And so that's when we talk about IVF being necessary, because with IVF, we have a strategy, a technique called ICSI, ICSI, which stands for intracytoplasmic sperm injection. And so if we do IVF and say we get 12 eggs from the female partner, now instead of needing 5 million or more good sperm, we would just need 12 good sperm, one for each egg, where we would take one sperm and inject it directly into one egg. So IVF allows us to overcome even very severe sperm abnormalities to give someone a great chance of having a child that's genetically theirs, even if the sperm quality is very poor. So IUI and IVF are both options for male factor infertility, depending on the severity of the sperm abnormalities. Mild to moderate, IUI is often a good option that will give a reasonable chance of success, and IVF will give a great chance of success, even with sometimes severely abnormal sperm results. All right, next question. I've seen people recommend vitamins and supplements. A number of these supplements are listed on top of prenatal vitamin daily. Is this something that you believe helps to aid in conception? So in general, in the United States, there's a trend towards using vitamins and supplements, even though study after study shows that most of these have no benefit and sometimes actually can cause harm. And so, for example, just last week, there was a big study that showed that taking a multivitamin for an average adult does not improve life expectancy and does not decrease overall mortality. Similarly, with most of the supplements that are marketed and advertised for fertility, they have not been conclusively shown to have any significant benefit. And so the prenatal vitamin is the only thing that I can recommend with confidence, because there's great data to show that the number one most important ingredient in the prenatal vitamin, the folic acid, if taken before pregnancy, can help build up your folic acid levels, and that is related in particular to decreasing certain types of birth defects, specifically spina bifida neural tube defects. Okay. The folic acid may also help with decreasing risk of miscarriage for certain individuals. So that's clear. That's beyond doubt. So the prenatal vitamins should be taken by anyone who is planning pregnancy or there's any chance of pregnancy occurring at any point. Beyond that, nothing has been demonstrated to be effective. And the one supplement that I mentioned earlier, the coenzyme Q10, that may have some benefit in improving egg quality is sometimes something I discuss with my patients who have very poor egg quality or very poor response to stimulation as an option to consider. But I would urge you not to experiment with other supplements out there. Supplements are not inspected or controlled or regulated by the FDA. And so unlike prescription drugs, where the government monitors, comes in regularly for inspections, and we hope does a good job of doing that, for supplements, there is no such oversight. And that means that you do not know that what you're getting in the tablet that you're taking is what it says on the label. So that may not at all be true. And there may be contaminants that are harmful, and studies that have been done on supplements show that that is often the case, that there may be harmful contaminants that you don't want, especially if you're trying to get pregnant, such as mercury and lead and testosterone and other things you really do not want to be taking. And so if you do use any supplements, I always recommend you go with a reputable brand, and particularly if they've had a third-party verification of their manufacturing process. So those will have a stamp like USP, which says that a third company, independent company, came in and inspected their manufacturing process and verified that what it says on the label is what's in the pill, and that they're doing a clean, good job of making their supplements. Next question is from a 37-year-old with, I assume, a balanced translocation with one viable embryo after PGTA. Why have we been advised to wait for a year after a pregnancy before another retrieval? So I'm going to read into this question. So I don't think that you need to wait for a year before another retrieval, but the recommendation is to wait for a year before another pregnancy occurs. Because what we want is for your uterus and your body to go back to normal as much as possible before another pregnancy occurs. And so what we know is if a pregnancy happens too soon after a previous pregnancy, then there's much higher risk of complications in that second pregnancy, especially intrauterine growth retardation, the baby not growing well. Sometimes there are placental problems, and sometimes, especially if you've had a C-section, there may not be adequate time for the uterus to heal, and there's high risk of uterine rupture. So a number of concerns if a second pregnancy happens too soon after the first one. And so the best optimal time to wait in these studies has been shown to be a year and a half. That's the optimal window for waiting before having another pregnancy. But we do realize that for some, we have to balance that risk of complications of early pregnancy versus waiting too long and having risks of complications increase due to age in pregnancy, as well as potentially some who need to conceive earlier because they're getting older and their fertility is declining. So we always have to balance that. And in general, waiting a year is sufficient because the biggest risks are in the first year, and there's less of a concern in the 6 months after the first year. So a year is a very reasonable recommendation for waiting before another pregnancy. Now, you said in the question, waiting for another retrieval. That is not the case. So once you've recovered from pregnancy and you've achieved a stable state where you're ovulating again, and everything is okay with your ovaries, you do not have to wait a year. You only need potentially a few months before going forward with stimulation, retrieval, getting the eggs, making the embryos, testing the embryos. It's just the transfer, putting the embryo in, you should wait for that year. What is the percentage of success with one round of egg retrieval? Does it typically take more than one to have several viable frozen embryos? There is, I wouldn't say a typical one. Yes, we can calculate an average rate of success, and that's something in the mid-30s right now in the United States, so something like 35%, I think, is the average success rate from one IVF cycle. But a more useful way to think about it would be, what was your chance of success? And that's something I would review with your doctor. So your individual situation allows us to do a rough calculation and estimate your chances of success. And that is driven most by your age. So age is the #1 predictor of success. And second, by your ovarian reserve testing. How many eggs do you still have left in storage? A lot or a little? And then your diagnosis. Why are you needing IVF? What is the cause or causes of infertility? And so the success rate varies dramatically, and it can be estimated for any one individual. And in fact, you can calculate yourself using a calculator available online from the Society for Assisted Reproductive Technology, SART, S-A-R-T. So if you go on their website, there is a calculator available to the public that if you put in the information that they request, it will spit out a number, a chance of live birth, to give you an idea of your chance of having a live birth, a baby, from 1 or 2 or 3 IVF cycles. And then the second part of the question was, does it take typically more than one to have several viable frozen embryos? And again, that depends. Again, the same predictors, age and ovarian reserve, predict how many eggs you're going to get and how many embryos you're going to get that can be frozen. And there's a fair amount of variability. And so it's impossible to predict exactly, but younger women with good ovarian reserve are likely to have several frozen blasts from one IVF cycle, whereas older women with poor ovarian reserve may not get any to freeze at all. So varies dramatically. Next question is, how successful is ICSI and Zymot performed together? Well, that's a very specific question, and the answer depends. The answer depends on why you need these things in the first place. So ICSI is intracytoplasmic sperm injection, where we take one sperm and inject it directly into the egg. And so when you ask how successful is ICSI, I'm not sure what the question is referring to. Is it the chance of fertilization, that the egg is fertilized and makes an embryo, or the ultimate success of making a baby? And so fertilization rates with ICSI in some studies are a little bit better sometimes than conventional IVF, and we just simply put one egg with a whole bunch of moving sperm and let them go at it and try to fertilize that egg in a more natural way. Zymot is a way of selecting sperm, and that selection process is not really shown to be helpful for most cases, but may be helpful in certain specific cases. So one specific example that I sometimes think about using it is to select sperm in cases where men have higher DNA fragmentation rates in their sperm. And so this may sometimes help select sperm that have less DNA fragmentation to improve the chance of success. But overall, great data is lacking, so we can't say that Zymot will make a significant difference in most people's cases. Next question is from a 23-year-old who had a frozen embryo transfer, who has PCOS and has a cyst on her ovaries, with the cyst unfortunately growing during pregnancy and rupturing, resulting in emergency surgery and loss of the left ovary and tube. Pregnancy has continued, but wondering about future transfers. Would this possibly happen again, or is that likely? So I'm very sorry to hear that. Of course, any emergency surgery is always very traumatic and scary and painful. But I'm glad that you're okay. It sounds like you've recovered. It is also sad to lose an ovary at a young age, but the good news is that you still have the other ovary, and you're young, and you should still be able to get lots of eggs from that other ovary if you need to do IVF again. If you have frozen embryos from the first IVF cycle, then you don't need ovaries at all, because even women without ovaries or hormones, we can still get a great chance of success with frozen embryos with some hormonal treatment. That's no different essentially from your first frozen embryo transfer cycle. So great odds of success. And the risk of recurrence of the cyst depends on what cyst you had. So some cysts are more likely to recur than others. For example, if this was a benign cyst adenoma or dermoid cyst, there is an increased risk of recurrence in your other ovary. If you've had it once, you may get it again in the future. But that doesn't have, we think, anything to do with the pregnancy itself or fertility treatment. So those cysts may come at any point in your life. But overall, the odds are that everything would be fine and you would not have another cyst in the near future and would not have such complications again. And it's even more unlikely that you would need an emergency surgery, because most of these benign cysts do not cause problems and certainly rarely do they cause rupture and emergency surgery. So that's an unlikely outcome. Most of the time, these cysts can be watched for years without any significant problems. If after 2 failed attempts at ICSI and PGTA frozen testing, with making it to day 5 but not 6, would it be worth it to try a day 3 transfer? So to provide some background, when we do IVF, we get the eggs and we combine them with the sperm, and then the embryos are created, and then we count the days after the retrieval. And so there are 2 days that most centers do transfers, either 3 days or 5 days after the egg retrieval. The vast number of transfers these days are done on day 5 because day 5 gives us better pregnancy rates. Why is that? Well, there are a number of reasons, but the main reason is that the embryos are showing us which are the ones that have the best chance of success. So if the embryo makes it to day 5 and reaches the blastocyst stage, that is a stronger embryo, because embryos that didn't make it were not likely to be normal, and so they would not have survived. And so by day 5, we see the best, strongest embryos, and that greatly improves our chance of success when we go to transfer that embryo into the uterus. So why would day 3 transfer be done? Well, some clinics or some physicians feel in certain cases it makes sense, because there's a possibility that what if an embryo does not survive in the laboratory to make it to day 5 and make a blastocyst, but maybe would have survived in the uterus, because maybe the uterus is a warmer, fuzzier, nicer place for that embryo for those 2 days. And so maybe that embryo would have had a better chance of success had we transferred on day 3 rather than day 5. So that's the strategy, the thinking behind that. I am not someone who subscribes to that strategy. I believe that our laboratory has gotten so good that overall in the field, we have figured out what that embryo needs for optimal survival. So in the laboratory, from day 3 to 5, the embryo is growing in an incubator where everything is rigorously controlled: the temperature, the oxygen concentration, the acidity, everything, all the nutrients in the culture. So the optimal conditions for growth are present in that culture, in that incubator for those 2 days. And I can't imagine that the environment in the uterus would be any better, likely worse, because that's an uncontrolled environment, and maybe there's inflammation or something else that's present in that individual's uterus that could be harmful to the embryo. So I believe that if under the best conditions in a laboratory that is good at growing embryos to blastocysts, if the embryo does not survive in that extended culture to day 5, it is very, very, very unlikely that it would have survived inside the uterus. So I rarely see any benefit to doing a day 3 transfer. It's mostly done for psychological reasons, so that individual feels that at least they gave it a shot, that at least they put the embryo in. But I don't think it helps at all in terms of improvement of success, and puts an individual through potentially an unnecessary transfer of an embryo that had essentially 0 chance of survival. I already had intrauterine insemination done and it didn't work. For how long do I have to wait to do the IVF? It's been a year now. Don't have to wait at all. So at any point, you can always progress to IVF, depending on your situation. I don't know if there are financial obstacles or logistical obstacles, but in general, there's no reason to ever wait to do IVF if you are already undergoing fertility treatment that I can think of. And so if you're ready for IVF, then absolutely going forward with IVF would make sense. So I would encourage you to speak with your fertility doctor and to discuss IVF and see if that's the right treatment for you at this point. Next question is from a 34-year-old with endometriosis, having done 1 round of IVF, 24 eggs were retrieved, 12 mature, 4 fertilized, and no embryos made it to the final day to be frozen. Very disappointing. Was there anything else we could do to increase our success before our next retrieval in September, we will be doing a microflare protocol for round 2. So very frustrating. Anytime you do IVF and you have nothing to show for it, and you have to start all over. So that's always a very disappointing, very frustrating situation to be in. There are potential things to consider. So sometimes we do suspect that it could be the endometriosis that is impacting your egg quality. And if that's the case, there are treatments for endometriosis that may be considered. So those treatments include surgery to try to remove endometriosis, or medications that treat endometriosis like GnRH agonists or antagonists. And so doing a treatment, one of those medications, sometimes for 2 months or so prior to doing another IVF cycle, in some cases may be advantageous. But again, here the data is unfortunately not very strong, so it's hard to be definitive to say definitely do this or definitely do that. But if you want to consider something, that's something I would discuss with your doctor. Is this an option for you? Does this make sense? Or does that simply delay your opportunity to do another IVF cycle? So there's pros and cons both ways. In general, you had a good response to stimulation with decent maturity rate, but poor fertilization rate. And so one thing I would certainly consider is if ICSI was not done, to consider using ICSI to try to improve the fertilization rates. Changing the protocol sometimes may help improve the quality of the eggs. But overall, you had a pretty good cycle with good response. Maybe waiting a little bit longer to do the trigger shot to try to get more mature eggs. Maybe using a different trigger shot if it wasn't done already, to do a combination of a Lupron and a high-dose HCG trigger shot. If the cycle allows it with 24 eggs, I would not have done that because of risk of hyperstimulation. So there are a number of things to still consider to try to improve, number one, the maturity rate, number two, the fertilization rate, number three, the egg quality. And yeah, I would certainly discuss that with your doctor. And I would not be giving up at this point. You respond, so that means that there's still a very good chance of success that next time you go through this process, you will have a better outcome. So I have hope for you, and I wish you the best of luck. So with that, we are approaching the end of our hour, and I hope that I've provided useful information that will help you in your fertility journeys. I wish all of you success. And if I can be of service or help, I encourage you to come see me so we can talk and explore your situations further. Good luck and good night.